had discussed this, but that time I think many of you were not there. So this was a 59-year-old anesthetist. Had tightness and breathlessness on climbing stairs about 3 days, increased to class 4 since one day. Patient was admitted to a outside hospital and treated as unstable angina with ECG changes and anterior wall and STEMI. Now, this patient actually was not improving, and then he was advised to undergo angiogram. And the patient himself is an anesthetist. He was not sure what was happening because, in spite of NTG heparin, he was not improving. That was the time when he came back to us. He was there in the other hospital, basically because of certain insurance issues. He belonged to the army, so he had to be there. And then once he realized there was something wrong which was going on, he came back to us. Now, this was the ECG which was taken in the emergency. Anyone wants to comment anything about this ECG? Any comments on this ECG? You can just read the ECG and tell us what you find here. Swaraj, you want to tell something? Dr. Rama? Okay. Farhan mentioned S1Q3T3 with T inversions in chest leads. So this patient, when he came to the emergency, what was very glaring at that time was that he had a grossly elevated jugular venous pressure. And along with that,
Rajiv,
sir,
he was admitted with this syndrome in another hospital where diagnosis of coronary artery disease, anterior wall subendocardial ischemia was made, and coronary angiogram was suggested. The echocardiogram was interpreted as normal. Then he came to us. Then we saw him. That was the background.
yes, sir.
After angiogram was suggested, he came to us for angiogram.
Yes. And his breathlessness was not improving, for which he was advised angiogram. And that's how he came back to us. So, as Farhan mentioned, if you look at this ECG, you have a S1Q3. That means there is a S wave in lead 1, there is a Q wave in lead L3, and there is a T inversion in lead L3. Now, the clue here was that when the patient came, he was quite significantly breathless. Jugular venous pressure was elevated, and he had a very wide split second heart sound. And then that immediately prompted a suspicion that patient might be having a predominant right-sided heart failure. And with breathlessness, with acute right heart failure, the first suspicion goes on to pulmonary thromboembolism. So when you suspect a particular condition, then you look for that in the ECG. Now, normally, if you just see the ECG, what is glaring is the T wave inversions in the anterior leads. So that's the reason why in the outside center, they thought it is an anterior non-QMI, anterior wall ischemia, and started treatment as NTG and heparin. Now, these T wave inversions can occur because of RV strain. So the S1Q3T3 is suggestive of a acute RV strain, pulmonary thromboembolism, and these T inversions, which are there in V1 to V4, that can occur not only in anterior wall NSTEMI or anterior wall ischemia, but it can occur in pulmonary thromboembolism because of acute RV strain. It is an indirect indicator of RV strain. So that immediately prompted a suspicion of pulmonary thromboembolism. And then, so this is just to show you the S1, Q3 and T3 pattern and the anterior wall ischemic changes. So suspicion of pulmonary thromboembolism. Now this is the echo. And when we talk about the echocardiogram, this is called the parasternal long axis view, where this is the left atrium, this is the left ventricle, and this is the aorta. So blood is going from the left atrium to left ventricle and the aorta. And this is the right ventricle. Normally, the right ventricle should be smaller than the left ventricle. Here you can see that the right ventricle is significantly dilated. Okay, so uh, then again, this is the apical view. That is, from the apex of the heart, you are seeing this is the apex of the heart. This is the base of the heart because the probe is near the apex. The apex of the heart comes above and the base comes below. So it will be inverted on echocardiogram. Now, this is the left atrium and left ventricle, and this is the right atrium and right ventricle. Now, normally the LA and LV should be bigger, RA and RV should be smaller. But you see here, the right atrium is grossly dilated, right ventricle is grossly dilated. And while this is playing, you will see one thrombus which is dancing here. We'll show you that thrombus. You're able to see this? This is the thrombus from the right atrium prolapsing into the right ventricle. Okay, so you don't require any other diagnosis to say that this patient is having pulmonary thromboembolism. So this is just to check the PA pressures, and this is the IVC. Okay, the IVC is IVC is the inferior vena cava. So normally the IVC will be less than 1.5 centimeters, and with respiration it will collapse. So with inspiration the IVC will collapse. But here you can see that it is grossly dilated, and it is not, even with inspiration it doesn't collapse. That is called as a plethoric IVC. You see, it's just remaining like that. Okay. So initially the diagnosis was nothing else except pulmonary thromboembolism. And then patient was thrombolized. He did not improve. So he was taken up for emergency surgery. And these are the clots which were removed during the thrombectomy, pulmonary thrombectomy. These were the clots which were removed. Okay. Then post-operatively, the patient became all right. Now you see the right ventricle, how small it has become. And the left ventricle has now become the prominent chamber. Again, if you, after some time, you'll get the apical four-chamber view. So you can see the apical four-chamber view now. This is the left atrium, left ventricle, right atrium, right ventricle, and you can see that the RARV has almost become normal. So this was pulmonary thromboembolism. Again, the presence of S1Q3 T3 and T inversions in the anterior leads that actually was misinterpreted as a anterior wall ischemia. So we are talking about ECG mimics. So this is a ECG mimic where patient had PT but was mistaken for an anterior wall non-QMI. I think we have some uh, questions. Okay, Dr. Sarika wants the ECG slide to be shown again. We'll just show you those ECG slides. Okay, so that is the ECG. So L1 showing the S wave. So S1Q3T3 means there is a S wave in L1, there is a Q wave in L3, and there is a T inversion in L3. That is what is meant by S1Q3T3. So you can see S1 here, Q wave in lead 3 and T wave inversion in lead 3. Is that clear, Dr. Sarika, or any other doubts? Okay, so we'll just move on with the presentation. So this is pulmonary thromboembolism being mistaken for a anterior wall ischemia.
Rajiv,
Sir.
see, the clue in this patient was not S1Q3, which is a non-specific finding actually. S1Q3 can be present in a lot of other situations. It's a normal variant also. The most important clue was elevated JVP, wide split second sound, and clear lungs with hypoxia. And echocardiogram confirmed it. And then while we were thinking about whether to give thrombolytic therapy or send him for surgery, he collapsed in the ICU, and emergency surgery was not undertaken. He had done well actually. He's still all right now. He continues to work. He was a smoker and ex-army officer actually, a doctor in the army. Thank you.
Yeah, he's still fine. This is, I think, way back almost 17 years now. So he's doing all right. But so the significance here is, suppose that was missed, that elevated JVP wide split was missed, the suspicion of PT was missed. And so typically this patient would have collapsed. You would have taken up for angiogram. Angio would have shown that it is normal. And then you don't know what happened. And he would have died. It's as simple as that. Okay? Because once, if you have not made us a diagnosis of PT, you will naturally not give thrombolysis, nor will you take up the patient for emergency surgery. So this patient would have died within couple of hours if the diagnosis of PT was not made. Okay.
Actually, it also brings out other aspects of how we practice medicine. Number one, each investigation or each component of evidence should be viewed in isolation first and then in combination. Like the electrocardiogram was misleading, you would say, and echocardiogram was done and is interpreted as normal in the other hospital. Shows the problems of echocardiography, how echocardiogram, which is an extension of a physical examination, is not very well done in majority of the places and individuals. So even echocardiograms can be wrong. Then clinical examination came the first clue. The echocardiogram redone confirmed it. So in other words, if you went by ECG alone or previous echocardiogram evidence, you would have gone ahead with the angiogram or whatever it is. But combining everything, which component of your evidence gives more clue in each patient is variable. That's the reason why look at everything in isolation, look at everything in together, combination. That helps. Thank you.
Yes, sir. So we'll just go to the next case. So this is a 55-year-old male, left shoulder pain since 6 hours, diagnosed as anterior wall and inferior wall MI outside. So he was shifted to our center for primary angioplasty. This is the ECG. I'll go to the question and again come back to the ECG. So the question is, what would you do next? You'll give thrombolysis, you'll do primary angioplasty, only conservative management with NTG heparin, or you would do something else. This is the ECG. You can give your comments what you would want to do. No one wants to do anything. Nobody is typing anything. Type something, whatever you feel is you would want to do, you can do.
Somebody asked window period. Window period, somebody asked Rajiv.
Yeah, window period was about 4 hours. Yeah, inferior wall MI and anterior wall MI was diagnosed outside. We are asking what will you do in this patient? Okay, somebody wants to do thrombolysis with tenecteplase. Any other ideas? Analgesics. Somebody felt it is very acute pericarditis, so give analgesics. Okay. Any other ideas? Primary angioplasty. Someone wants to do primary angioplasty. Okay. Any more ideas? Only 3-4 have replied. Primary angioplasty, PCI capable center. Okay. So it was sent to our center. We are primary PCI capable. So someone mentioned primary angioplasty. So presently primary angioplasty is winning the game. 3 for primary angioplasty, 1 analgesic and 1 thrombolysis. Any other ideas anyone has? Okay, so Farhan, can you just start reading this ECG for us? The way we described how we read a ECG, can you just start reading the ECG for us? So pericarditis is now become 2. Someone else thought pericarditis and some other option was the answer.
Good morning, sir.
Morning, Farhan. Let's read the ECG together.
This, uh, this is a 12 lead ECG.
Okay.
of heart rate about
No, first it has to be identification and then standardization.
yes, sir.
Okay, 55-year-old male. We don't have
55-year-old male,
time. Okay.
12 lead ECG of a 55-year-old male patient
Hmm.
with normal standardization,
Hmm.
heart rate of about 50, 50 beats per minute, sir.
It's around 25, so probably around
25,
60 per minute.
60 beats per
Okay, heart rate of 60 per
uh,
minute. Hmm.
regular rhythm, not normal sinus rhythm, sir.
So it's a normal sinus rhythm. Okay.
Previous,
We didn't hear you, sir.
the height of P waves are
No, you didn't talk
short,
about
sir, short
axis.
P waves.
After rate and
Yeah,
rhythm, you have
axis.
to tell about
Uh,
axis.
showing left axis deviation, sir.
So it's not actually left axis because L2 is equiphasic and AVL is tall R wave. So it's minus 30. So still minus 30, you can consider it as just borderline left axis. So it's minus 30 degrees. Okay. Then after axis,
And P waves, sir. P
uh,
waves.
hmm.
Shorter P waves, sir.
P waves, there won't be anything like short P waves. So I think P waves are normal. In L2 and even if you are seeing whether there is any left atrial overload or right atrial overload. So both are not there. So P waves are normal. Okay. Then
Then PR segment, sir. PR segment is depressed, sir.
you want to talk about PR segment or
L2,
you want to talk about PR interval?
PR interval. PR
Okay.
interval
What is the PR interval here?
is shorter, sir.
How
Like
much?
less than maybe 0.04 to 0.08 seconds.
Around 80 milliseconds.
80 milliseconds.
So some eureka, some bulb suddenly brightens up in your mind. Suddenly when you see short PR.
Yes, it could be like short PR. Differentials could be like tachycardia and also in acute pericarditis also presentation is like that.
Why acute
History.
pericarditis will produce short PR interval? What is the first thing you suspect when you have a short PR interval?
Yeah.
Pericarditis, I'll be very upset about it.
Yeah. What do you suspect if you have a short PR interval? Accessory pathway, right? WPW syndrome.
Yeah.
So now you come to QRS complex. So what do you want to see in QRS complex when you're suspecting WPW syndrome? Delta waves, right?
Yes, sir.
So are
I
you able
think
to see delta
after
waves
P wave,
here?
yes,
Initial
sir.
part of
After
QRS
P
complex.
waves of QRS. Yes.
Yeah. See that?
In V1. Yes, sir.
L1. Okay. Here it is negative. L3, you are able to see the slurring here. AVL, you are able to see the slurring here. Initial part. AVF. Then V1, the slurring. V2, you are able to see the slurring. V3, you are able to see the slurring. V4, V5, V6. Okay. So there are delta waves which are present. And then the rest of the QRS seems to be all right. Then T wave ST segment.
Then T waves. ST segment is concave ST elevation. Yes, sir. Only minimal is there.
Yeah, it doesn't fit into the
Longitudinal.
criteria. Then T
Yes,
waves,
sir. T waves are tall peaks, sir. Tall peak T waves.
slightly tall probably, slightly tall
Yes,
and peak T waves. QT interval, at least by
sir.
eyeballing, QT interval is normal or abnormal by rule of thumb?
Normal, sir. Normal. Less
Normal.
than 50% of RM.
Okay. So what is the diagnosis here? ECG diagnosis is
WPD.
WPW syndrome.
Accessory pathways.
Now, how did you pick up WPW syndrome and why did you miss why everybody missed WPW syndrome?
Because of PR shortening as well as this presence of
Delta.
delta waves.
No, but initially, why everybody missed? Somebody wanted primary angioplasty, somebody wanted analgesic, somebody wanted thrombolysis. Why it was missed?
No one followed the steps of
Very
reading
good.
ECG.
Thank you. Thank you very much. I think my day is made now. Okay, so we warned you before that we'll make you read the ECG and you will commit the mistake if you don't follow the steps. I think you should be kind enough. I'm a very kind person, right? I already warned you while talking about steps of ECG that we'll tell you and you'll miss it. And then, in spite of we telling, still all of you jumped for primary angioplasty and then missed a WPW syndrome. So this patient, what he has is a WPW syndrome with a delta wave. Okay, so it's not anything which patient needs to be done. It was a atypical pain. Okay, so the first clue you see here, left shoulder pains in 6 hours. So it was not at all a typical pain. It was a atypical pain. And then we sent back the patient and we told him that if he has some tachycardia or something, we'll do a EPS RFA. So the answer is something else. And what needs to be done is, if needed, a EPS RFA. Otherwise, nothing needs to be done for a WPW. Okay. So this is a classical WPW syndrome. Now, I'm sure some of the cardiology DNBs might be feeling very happy that others are getting ragged. Now, we'll ask them where the pathway is. I think Ashish is there. Ashish, I don't know if Kalyan is there. Vamshi is there. Shanti is there. So, can someone tell me where the pathway is? So, there is an accessory pathway. Where is the pathway? Okay, read up about that. Because others, we don't want to bore them with that. We'll come back to this later. Okay, so that is the WPW pattern. Okay, now this is the next.
Dr. Rajiv,
Sir,
they should also want to know what is the real description of the left shoulder pain. The more detailed description of left shoulder pain would have given them some idea that was a non-cardiac left shoulder pain and look for alternatives. No, nobody asked. Again, everything in combination and everything in isolation. Left shoulder pain should not be taken for granted. It should be, suppose the left shoulder pain was changing with the movement of the arm and also neck pain. Similar pain happened in the past, and it's, all those things do help. But please consider everything together.
yeah. Okay, now we'll come to the next case. So this is a 25-year-old engineer, severe catchy pleuritic type of pain. And this is the ECG. So what is your diagnosis here? You know, nobody's, Amir just typed Terry. Okay, acute pericarditis. So now the question is, okay, most of them have written acute pericarditis. Here also everyone has said pericarditis. Now the question is, why do you say pericarditis? I'll say this is anterior wall MI. Inferior wall MI, we spoke so much about wrap around LAD, two arteries getting occluded, all that we told, right? So I say this is anterior wall MI. Why do you say it is a pericarditis? Can someone unmute and tell us how do you differentiate a ST elevation of acute pericarditis from ST elevation of myocardial infarction? That's very important, right? Imagine acute pericarditis, you give thrombolysis, patient might go into tamponade. Because of the inflammation, he might suddenly bleed there and go into tamponade. Versus if it is actually MI and you are not giving thrombolysis, that is dangerous to the patient, right? So can someone tell us how you differentiate acute
Sir,
pericarditis?
catchy pain is one of the clues, sir, for pericarditis during inspiration.
Yeah.
But as the ECG is showing slight J point elevation with hyperacute T waves, typical chest pain history could also suggest acute MI, sir.
Okay. So of course, you have to take the clinical presentation into picture before you start suspecting pericarditis itself. Otherwise, it's impossible just based on ECG, somebody will be brilliant to diagnose. So it starts with history, that's right. But just based on ECG, how do you differentiate? So now you are suspecting pericarditis based on your history, and you have taken this ECG, and now you want to know whether this ECG is fitting into your clinical diagnosis of pericarditis or against your diagnosis of acute pericarditis. So how do you differentiate?
There's a global concave ST elevation, sir. PR depression is
One
there.
is one is so almost in one line you told many features. First is that the patient will have global ST depression, ST elevations. So it's not fitting into a particular vascular territory. Whereas in MI, it fits into a vascular territory, inferior, anterior, lateral, whatever. But here you can see that you are having ST elevations in L1, you are having in L2, you are having in L3, you are having ST elevations in V1 to V6. So there are global ST elevations. Okay. The second thing which Amir mentioned was concave upwards. So you see the ECG here, you can see the classical concave upwards ST elevations. Whereas in MI, it is more of a convex. Here it is concave upwards. Third, a very important clue is a PR segment depression. Okay, so you look at the PR segments here. Okay, you can see the PR segment depression. See lead AVF. Okay, you are able to see here, see the ST, see the TP segment, and see the PR segment. So this is the TP segment, this is the PR segment, and you can see that the PR has gone down. Okay, so presence of PR segment depression. So global ST elevations, concave upwards, and PR segment depression. They are the clues. Then finally, if you have a series of ECGs, you should look at how they evolve. So in acute pericarditis, there will be 4 stages, and STs will go up, then STs will come down, and then the Ts will get inverted. Whereas in acute MI, you can still have ST elevation, but the Ts can get inverted. Okay. So the evolution of pericarditis is always stage wise. So first some ST elevation, maximum ST elevation, coming back to normalcy, and then T inversions. Whereas T inversions with ST elevations can occur in acute MI. So the evolution again helps you. And of course the PR segment depression. So here the diagnosis is acute pericarditis. Now, one significance we told you that if the patient comes to the ER, and so I'll give you an example of one case. The patient had a diaphragmatic hernia and the patient was operated. Next day, patient started complaining of severe pain. And when the patient started complaining of severe pain, uh, the ECG was taken, which showed ST elevation. So immediately a referral was given again for a primary angioplasty. So then the cardiologist went there and saw something like the ECG was something like this. And then there was a suspicion of pericarditis. Echo was done and that showed pericardial effusion. So the cause there, post-surgical acute pericarditis. It has nothing to do with acute MI. LV was totally normal. Okay, so that is one example. Another example, when we were talking about auscultation, I told you about a pericardial rub. We gave that example. So, elderly lady had some renal failure, some acute or chronic renal insufficiency, started developing chest pain, and was told that patient has unstable angina. NTG heparin is started. And one day patient didn't respond, again NTG was increased. Still didn't respond, again NTG was increased. So continuously being treated as unstable angina. Then we went and auscultated, we realized that patient had a pericardial rub. So it was a acute kidney injury and acute pericarditis. And all of you know that acute pericarditis is an indication for dialysis. You can't leave the patient just like that. So what the patient required was not NTG heparin. Patient required dialysis. So acute pericarditis diagnosed, uremic pericarditis taken to the dialysis room, dialysis done. After 3 days, pain disappeared. Okay, so it has significant clinical relevance, the correlation of ECG as well as the symptom of pericarditis, that catchy type of pain with increase with inspiration. Okay. Okay, why PR segment depression is seen? Sir, you want to answer that?
PR segment depression is a feature of atrial pericarditis, atrial injury.
Okay, now the next case, elderly woman with worsening breathlessness. Patient already had a pre-existing left bundle branch block. Blood pressure was 150 by 110, cardiovascular system feeble A2, ejection systolic murmur, chest was clear. Patient had severe LV dysfunction and patient had some aortic stenosis also with about 20 gradient. Now this is the ECG which was taken. So what is your diagnosis? Acute MI, only LBBB with dysynchrony, accelerated hypertension producing CHF, or a severe aortic stenosis producing CHF. So remember here that this is pre-existing LBBB. New onset LBBB anyway is anterior wall MI. So you treat it as a acute MI. But here it is a pre-existing LBBB with these changes. So what is the diagnosis?
Sir, any radiation of, I mean, the carotid pulsation, any in the history?
Um, what exactly is your question? You want to know whether ejection systolic murmur is radiating to carotids?
Yes, sir.
Yeah, it's radiating to carotids.
So there's a J point elevation of more than 5 in chest lead, sir.
Which chest lead?
Lead V2, sir. I mean, yeah.
Yeah, so Amish says that there is a ST elevation of around 5 I won't say more than 5, but at least definitely it is about just above 5, probably around 6 in V2. Okay. So why are you telling all that to us?
Yes, sir, like there's a criteria, sir, for an MI and an LVB, sir.
So first question is, what is your diagnosis here? You think the heart failure is because of acute MI, dysynchrony, accelerated hypertension, severe aortic stenosis. Then we'll come to criteria.
Uh, a little confused, sir.
That's okay, no problem. This patient will be there in front of you in the ER. So you can't run off from there. No? You can't say that I'm confused, madam. So you're on
No,
your
sir.
own.
Yes, sir.
You're on your own and you can't run off from there. You have to commit on something.
ECG wise, sir. Yes.
Yeah, you're already starting. When you have started talking about the criteria, then there is some diagnosis in your mind, right?
Yes,
You
that could be
can't
an acute
start.
MI, sir.
So you think it's
Still
acute.
going. Yes, sir.
Okay. Anyone else wants to tell anything else? Anyone else has any other ideas?
Because the chest is clear, sir, and the SOB is not no.
Now the chest has become clear, but she's in LVF basically. She's in heart failure. Okay, so now you tell us some criteria you were telling. We are not aware. Can you tell us what that is?
In the chest leads with concordant complexes with more than 5 J point elevation. The background of LBB is an indication of an acute MI, sir.
Okay, so we'll come to that. So that's the famous Garbosa's
Barbosa, yes, sir,
criteria.
yes, sir, yes.
Okay, so lot of people were asking when we were discussing about ECG about the Garbosa criteria. So Garbosa criteria, you have acute myocardial infarction and probably a chronic ischemia. For acute MI, the criteria are ST elevation of more than 1 mm with concordant QRS. We'll come to what it means. ST deviation of more than 5 mm with discordant QRS. ST depression of more than 1 mm in V1 to V3. Positive T waves in V5 to V6. Whereas a old MI in LBBB is indicated by Q waves in L1, ABL, V5, V6 or QR during ventricular ectopy or ventricular tachycardia. So we know that in the patients with left bundle branch block, the first thing to disappear is the septal depolarization. Okay. Septal depolarization, we mentioned that there are small Q waves which are there in L1, AVL, V5 and V6. And we said the septal depolarization which occurs is from left to right. That's the reason why you get Q waves. So if you see L1, AVL, V5 and V6, there will be a small Q followed by a tall R wave. Okay, now in LBBB, the first thing to disappear is this septal Q wave. Okay, so LBBB we said will be directly R complexes. So the Q wave generally will disappear. In V1, you'll have the small R wave. Okay, so the R in V1 and the Q wave in L1, AVL and V5, V6 will disappear in left bundle branch block. So if you have a Q wave here, it indicates that it is a old infarct. That's what is mentioned here. So if Q in L1 AVL, V5, V6 is there, it indicates that the patient is having old infarction. Okay. Now let's come back to the Garbosa criteria for acute MI. So what is this concordance and discordance? So discordance means whenever you have a negative predominant QRS, you have a positive ST segment and a positive T wave. This is the normal discordance. So when you have negative QRS complex, you'll have ST elevation and you'll have upright T wave. When you have a tall R wave, you'll have ST depression and you'll have an inverted T wave. This is discordance. And this is normal. Okay. So that means whenever you have a negative wave, negative QRS, ST and T wave will go into the opposite direction. So positive R, it will be negative ST depression or it will be ST depression and negative T wave. Q wave will produce ST elevation and positive R wave. Okay. Now when the opposite occurs, it is called as concordant. That means you have a negative QRS complex, but you have ST depression. Or you have a positive QRS complex and you have ST elevation. Then it is concordant, which is abnormal. Okay, so normally, whenever you have the depolarization abnormality, the repolarization waves, the ST segment and the T waves always go in the direction opposite to the depolarization. So when you have negative QRS, you'll have ST elevation and upright T waves. When you have positive R wave, you'll have ST depression and a negative T wave. When the ST segment goes in the same direction as the QRS, it is called as concordant and that is abnormal. Okay. So now what is the Garbosa criteria? ST elevation more than 1 mm with concordant QRS. That means if you have a negative QRS complex, but you have ST depression which is 1 mm, or you have a tall R wave, but you have a ST elevation which is more than 1 mm, then it satisfies the Garbosa's criteria. Okay. Two, this is what Amir was mentioning. ST deviation more than 5 mm with discordant QRS. So normally you will have negative with ST elevation, but this is less than 5 mm. If you have a situation where this is more than 5 mm, or you have a R wave with a ST depression more than 5 mm, then it indicates that there is a discordant change, but it is more than 5 mm, which again satisfies the Garbosa's criteria. Okay. ST depression more than 1 mm in V1 to V3, it's almost same, because in LBBB, you will have the negative waves in V1 to V3. So if they have ST depressions, it again indicates that it is MI in the presence of LBB. Positive T wave. So we said in V5, V6, you'll have a M pattern, okay, and a negative ST depression and T wave. So now you have the same LBBB pattern, but suddenly the T wave has become upright. Then that indicates that it is a MI which is going on. There is a ischemia which is going on in the presence of left bundle branch. So let's go back to our ECG now. Now you see here, okay, L1, there is concordant, right? You have a tall R wave, but you have a ST elevation. What you expect is a ST depression, but you are having, like you see here in V6, you expect the ST depression and inverted T wave, but here you are having ST elevation. Okay. Similarly, you see here in L2, you have a predominant negative QRS complex, but you are having ST depression. Okay, here it is. Similarly, you see AVL. In AVL, you have a predominant R wave. Again, you are having ST elevation. Now in V2, this is what Amir was mentioning, that if you see the baseline and you look at the ST segment elevation, it is more than 5 mm. Okay, so it is satisfying all the criteria of a patient having a acute MI. So this patient is LBBB with a acute MI. So the cause of heart failure here was acute MI. So patient requires some revascularization. What to do about aortic stenosis, dysynchrony, all that can be looked after later. But here patient is having a acute MI which is ongoing in the presence of underlying left bundle branch. Okay. Then there are another two important criteria which are famous criteria rather, which are called the Cabrera criteria and the Chapman criteria. This Cabrera and Chapman is again for a chronic ischemia. It is not for a acute MI. Okay. So Cabrera criteria is slurring of the S wave at 40 milliseconds in V3 and V4. Okay. So if you see V3 or V4, you can see the S wave here and you can see the slurring here. Okay. So this is the Cabrera criteria. Chapman is the notch in the R wave in L1, AVL, and V6. Okay, so you can see here L1, you can see the notch here. AVL, you can see the notch here. V6, you can see the notch here. So on the upslope, when you are having a notch, it's called Chapman. Again, upslope of S wave, when you are having a notch, it is called as a Cabrera criteria. So this is the Cabrera and Chapman criteria, which occurs in patients with left bundle branch block with a chronic ischemia. Okay, so in this case, the diagnosis is acute myocardial infarction. So what are the non-ischemic causes of ST segment and T wave changes? So it can be normal variant like early repolarization, left ventricular hypertrophy, bundle branch block, myocarditis, acute pericarditis, hyperkalemia, pre-excitation, Brugada syndrome, after cardiogenic cardioversion or shock, patients with anemia. Any of these things can produce STT changes, which can mimic a ischemia or acute myocardial infarction. Okay, so that is as far as some of the ECG mimics are concerned. So next from tomorrow, we'll keep showing you multiple ECGs, different types of ECGs in different conditions, and one of you by rotation can read those ECGs. Some of them we have already covered in this presentation. So any questions on what we discussed today? Sir, you want to add something?
Can you go back to the DCG? we can see that L1 AVL is an important clue. That is an LBBB ST elevation T wave inversion. This is classically suggestive, but you don't see that in the chest leads. The reason why you don't see that in chest leads is whenever you have L1 AVL like that, the leads that resemble L1 AVL will be generally V5, V6, but because the placement of the chest leads, here it's not shown. If you take V7, V8, etc., then they will resemble V5, L1 AVL. That will be an important clue also if you have doubts. So always if you have L1 AVL don't resemble V5, V6, take leads V7, V8, etc., then that helps actually.
Any questions, any comments? Kumar sir, anything you would like to add?
No, can you show that slide again? The criteria slide.
This one, sir.
Okay, thank you.
Anyone has any other questions?
Sir, I have one question, sir.
Yeah.
Sir, can a new onset LBB comes as a normal coronary, sir? Did you see any case, any experience you want to share, sir?
So again, important question. I think Amir, because he's there in the ER, he's asking all practical questions. These are the challenges which you face in the ER when the patient comes. So again, Amir, what is important is the clinical situation. So a patient, 20-year-old, he's running and all that, and he comes and suddenly you find some LBBB. You don't diagnose new onset LBBB and take him for primary angioplasty. 60-year-old recurrent with risk factors comes with classical angina. You take the ECG and then you realize patient has LBBB. Even if you don't know whether previously the patient had LBBB or not, you are going to take up for revascularization. Okay. So the new onset LBBB, the definition you have to interpret in the context of the clinical situation. There can be rate-related left bundle branch block. So we recently again had a patient. Patient had urinary tract infection, urosepsis, was advised to do a DJ stenting because of urosepsis. And then ECG showed LBBB. And patient is asked, then they asked for a cardiology opinion, again for angiogram, angioplasty and all that. Immediately once ECG changes are there, troponin is sent. Troponin naturally will be grossly positive. So there what happened was patient developed atrial flutter. Atrial flutter produced rate-related left bundle branch block. So it was the high heart rate which was producing LBBB. So we said nothing to be done, just control the rate, continue treatment for urosepsis, doesn't require coronary evaluation. So the treatment was started, flutter was reverted, and within about 24 hours, the ECG changed over to normal sinus rhythm, LBBB disappeared. Okay. So I mean, this case by definition is new onset LBBB. But the patient doesn't require anything because here it is the flutter which caused high heart rates. Whenever there is a high heart rate, there's a possibility one of the bundles will start conducting slowly. So here the left bundle started conducting slowly, so he developed a rate-related LBB. So it doesn't require anything. So it's the clinical context in which you need to interpret it.
Okay, sir. Thanks, sir.
Any other questions? We'll go to book reading, sir.
Not much time today, Rajiv.
Yeah, anyway, we wanted others to tell us about their mission statements.
Okay.
We have to first ask them to tell that and then continue with the other
Yeah, rate-related LBBB, while we are talking about rate-related bundle branch block, usually or most commonly resembles RBBB. LBBB pattern is uncommon. When it happens, once you have issues settled down, always look for underlying conduction abnormality or a left ventricular disease of some kind. You should investigate later.
Yes, sir. So anyone wants to tell us about any mission statement which they have looked at? Farhan, anything you want to tell about that? Last time Saujanya mentioned. I don't know if Farhan, are you there or?
Yes, sir, I'm there.
Yeah. Anything you thought about what you want to do in life? Your mission statement?
Yeah, I want to be better physician as well as good human being, sir.
Yeah, that's good, Farhan. I think that is the most challenging thing now to do. Then Swaraj, are you there? One Sai Swaraj's iPad is there. I don't know if it's the same Swaraj or somebody else.
Hello, good morning, sir.
Morning, Swaraj.
Yes, sir. I am Swaraj only, sir. My phone got repaired, sir.
Okay, as long as it has got repaired, it is okay.
Yes.
Tell us, Swaraj.
Sir, my mission statement is so I have to learn a lot, sir, in this medicine. Become a good physician first, and also a good human being. And whenever possible, I want to teach my juniors or fellows to whatever I learn.
Okay, that is fantastic. So, have you started teaching somebody?
Sir, not yet, sir.
So you
Like
should start off.
basics of ECG like that. I can.
No, you teach whatever, uh, whatever, whatever you can teach. I think about 2-3 minutes. I'll just request Dr. Somaraju to tell us about teaching people. Then I'll give my comments also about him.
See, anyway, before we talk about teaching, I just wanted to also tell them, when you say some may leave, others join, in the joining, any of you can join in this journey anytime. It need not be after you become a clinician and all the examinations you finished and you became qualified. You may start this journey even when you are a student, actually. Now, in the modified version of medical education, American Medical Association came out with an idea that a medical student can start looking after patients, including home care. They continue to follow them up, etc. So start with patient-centeredness, start with becoming knowledgeable, start with being part of a team. You need not wait until you become a very senior doctor to become a team member. So even students can become part of a team, and then how it can be done some other time we'll discuss. And also, you need not all of us need not be in one hospital or one institution. It's medicine without borders. We can be anywhere, any hospital we are working. We can still be doing a lot of things together. Just wanted to say that. About teaching, yes, when you are when you are a junior student and when you are a medical student or a postgraduate, you are not ready to teach. But mind you, the patient can be taught, patient's family can be taught, and then explain the illness to the patient, explain issues to the patient. But when you do that, they will listen to you with attention, because most of the seniors don't have enough time to explain all this to the patients. So get into that habit. But when you do that, show that you are not in a hurry when you go for a round. And take a chair, sit, and show that you have concern, you have time. And also, the other way of showing that you care for them is go earlier to the hospital than anyone else, leave the hospital later than anyone else. That convinces them. So start doing it. Start teaching not only patient and family, but also the rest of the staff in the hospital. Some of them need not be doctors or nurses, other people in the hospital. Start doing that. They will be too ready to listen. Thank you.
You didn't tell about tea and samosa, sir. So I think we are just running out of time. We'll start about teaching, because Swaraj brought up an interesting aspect about his passion for teaching. Actually, we are looking for competition. Yeah, people who can teach. So we'll talk about it tomorrow, about teaching, and then we'll go on to others' mission statements. I think we are running out of time, so we'll close the session for today. And thanks everyone for attending and also participating. See,